Hi, this is Juliana Vanderhoven doing NG tube insertion. So the reason for NG tube insertion, this one at least is going to be for decompression. We are using, for this patient, we are going to be using a double Lulen Salem Sump 12 French. I do not have a actual nasogastric tube, so we are going to pretend that this catheter is tube. We want that for a real person, but for this person, we'll do what we can. Perfect. Next, we do have our tape. Tape is going to be to place it on the nose in order to anchor the tubing, also to mark on the tube where it needs to be placed into as far as it can go, and also to put some on the tube itself in order to pin it to the gown if the patient had it. Next, we have our 15 ml syringe. This is going to be used to pull out the gastric aspirate and so we can test to make sure that what we are withdrawing is gastric acid. We'll check by the pH strips that we have right here, along with the marker right here. In terms of when we're actually inserting it, we do have our soaker pad to place onto to drape over the client so it doesn't get over the gown if they do possibly vomit or maybe throw up something. We have tissue papers, and we would also have a save-a-day tray. We do have our clean gloves, as this is a clean procedure, not a sterile procedure, as the esophagus and everything else like that is not sterile. Finally, we do also have our lubricant, so we can lubricate the tip of the NG tube so it does not irritate the nasal mucous mucosa. And finally, we do have our flashlight, so we can check in the mouth and the nares to make sure they are patent, and also to ensure that the tubing is going down and not coiling, and also a cup of water with a straw so that the patient can swallow the water as the tube is going down to ensure it goes into the esophagus, not the trachea. Perfect. So I'm going to start my procedure now. So hi there, Mr. Gale. I'm Juliana. I'm a term 4 nursing student from Langara, and I'm going to be inserting a nasogastric tube for you. Is that okay? Yes? Okay, perfect. So have you had an NG tube beforehand? You have? Okay, perfect. And how did that go beforehand? It went okay? Did it, any chance any adverse events happen with it? No? Okay. And do you by chance remember which nares it went into? Was it your left nostril or right nostril? It was your right nostril. Okay, perfect. So what we are going to do is I have cavity wiped this table beforehand. So I am going to first open up my packages. So we do have our tubing. Make sure my tube is in here. I'm going to open up my lubricant. And so, Mr. Gale, I'm just going to put this soaker pad onto your chest, okay? Perfect. Now what we're going to do now is we're going to get the tape. So I'm getting my first piece of tape, and I am going to rip it down halfway in the middle. This is so when I put it down onto the nose, it can wrap around the tube itself to ensure that it sticks. And then we are going to have one other piece of tape. This is going to be placed onto the tube itself for a marker. And finding the last piece of tape is going to be used to actually put it on the tube after it's been inserted in order to put the safety pin so it can be attached. Right. So what I'm going to do is I'm going to take out my nasogastric tube, and I am going to stretch it. I am not going to bend it, as if I do that, then the wire will not bend back. And what we are going to do is we are going to take the tubing, go from the nares to the ear, pick that up, and from the ear to, let's say, here. If anything, you would go down to the sternum. That would be the best indicator for in terms of the length. This tubing I have for it is not long enough, so I am going to pretend it is here. So we are going to take our tape, and we are going to place it onto here. So this is the marker for myself as I'm inserting it to make sure that I don't go any farther. Are you feeling okay there, Mr. Gale? Yeah? Okay. So we do have our tubing here. You get that? Put on some clean gloves. Ideally, I would have put on the clean gloves before I would have taken out the NG tube. So we will get our lubricant. And by chance, Mr. Gale, have you had any skull fractures, any nasal damage or anything sorts for the last while? You have not. Okay, perfect. So we have this ready, and we are going to insert with the dominant hand. Okay, we're going to insert now. It's going to start feeling weird. Okay, Mr. Gale? Okay. Inserting. And let's say right here, we do hit the trachea and we hear him gag a little bit. Okay, Mr. Gale? So it has hit the back of your throat, okay? Let me just double check to make sure it's in your throat. Yeah? Okay, so what I'm going to have to do is you're going to have to swallow. Okay? And then as you're swallowing, I'm going to advance the tubing, okay? So swallow and swallow and swallow, okay? Oh, it's going. Perfect. Good, keep going, keep going, keep going. Okay. We've made it there, Mr. Gale. Good job. How are you feeling? Any difficulty breathing? No? Okay. Perfect. So what we're just going to do, let me just quickly double check. Okay, it has gone down. So now we are going to check the gastric aspirate now. So we're going to insert it and withdraw some gastric aspirate. You can see with the color, it'd be maybe greenish, you know, that bile color, maybe cloudy. We would get our gastric pH strip and check it. So let's say it says 3, that's within the range that you're looking for the stomach. So we do know that it is in the correct area. Then we'll confirm it with a CT scan to make sure it is correct. So then what we are going to do is we are going to get our tape. We are going to place it on the nose. And then what's going to happen is half tape is going to wrap one way. So one half is going to wrap one way around the tube, and the other half is going to wrap the other way around the tube. This is to prevent it from going any farther down, and to prevent it from being pulled out possibly. So we have our tube there. It's a little awkward, that's okay. And then we do have our tube. So what I would do is we would do this, get a safety pin, and then it would be pinned onto their gown to make sure that it's staying in the right position. Okay, Mr. Gale, so how does that? Can you breathe fine? Yeah? How are you talking? Is any difficulties? No? Okay. So then at this point, the NG tube is inserted. Patient is having no complications. So what we would do is then we could possibly connect it to suction and then start withdrawing any of the gastric fluid. Perfect. And that is NG tube insertion. Hi, I'm Juliana Vanderhoven, and this is demonstration for wound care. So for this one, this is a complex wound care that we are going to be doing dressing for. So the tools that I do have for my kit is I do have a wound dressing kit right here. We have cotton tip applicators. I would have more if I did have them. We do have our irrigation syringe. This is a 20 ml syringe. Most appropriate one is a 30 ml syringe along with an irrigation tip. This is just the standard one. We do have our soaker pad that we're going to place underneath our client. We do have our measuring tool, so it either measures the circumference, the length, the width, and whatnot. We do have extra gauze sponges, smaller and larger sizes. I would also have a abdominal pad. I don't have one at the moment. We would have a saline bottle with us, our sterile gloves, as this is a sterile procedure, and also tape in order to tape our thing. So I would just go through. So hi Mr. Gale, my name is Juliana. So I'm going to be doing the wound care for you. So 30 minutes ago I did give you your pain medications. So we are just going to go ahead with our actual demonstration and the actual wound care. So are you good with staying on your side for the rest of the procedure? You are? Okay, perfect. So this is my side table. We would pretend to be over here to make the triangle. So what we are going to do is we are then going to move my items over to the side and then create my sterile area. So first, we shall open to the front, 2 ways to the side, and finally, ideally I'd have a larger table, and with my tweezers, move it over here, and I do have my sterile area. So this we can put over here. In the situation, I would use this extra area to put right underneath the area, just so I could have an extra extension of my sterile field. I'm just going to put my tweezers right here for the moment. And then what we are going to do is we are going to place all of my instruments into the sterile area. This is my syringe. Going to place these here. I'm going to put them within the 1-inch border because this is a sterile procedure, so I do not need to keep them within grabbing distance. I'm going to take everything out of my tray. Perfect. And previously I did look at the wound. It is packed with gauze sponges, so that's why I have brought gauze sponges with me. What we are going to do is we're going to take the garbage bag, throw it to the outside. I'm just going to put this down for a minute. We're just going to put our garbage right here. We are going to drop high, ideally. Grab our next one. This is our irrigation tip. There, drop high. Next, our cotton tip applicators. These are going to be used for the measurement of the tool and also to check for any undermining and any tunneling. And as I said, there is quite a few of the gauze sponges I am going to need, so I'm going to make sure that I have a good collection of them. Okay, again, we're still dropping high. And then we are going to use gauze sponges. Ideally, we would be having either a drain sponge, just because of the size of the wound, to soak up. We're going to use these extra large sponges to possibly drain and to get any of the excess fluid that we are going to have after we do irrigation. And then we would also have an abdominal pad. As I do not have one, I'm going to use a gauze sponge as one. Perfect. So we have everything that we need within our sterile field. We are now going to no longer use those tweezers. And what I will do is, as I've cappy wiped the counter beforehand, I am going to get pieces of tape ready. This is to ensure that when I am actually putting on the bandage itself, I'm not taking extra time, and I'm going to be as efficient as possible. Perfect. So I now have everything ready. I am going to use my clean gloves. So I would do hand sanitization before this. Clean my hands and put on some clean gloves. You could do this during the procedure as well, as we are setting up the wound care kit. So what you would do is you would remove the dressing from our patient. Ideally, skin would not be what this is, but improvisation is what we have. Improvisation is all we have. Oh, there goes my wound. So then I look at the dressing. I don't really see any drainage on it. Wound looks clear. Not really seeing any bleeding at the moment. Good edges. So my area is ready. I've taken off the old wound. And I want to go to sterile procedure. Drop high. And so we would get our sterile gloves and place them on. So as taught in lab, we do non-dominant hand first. And then our dominant hand. I'm now sterile. Previously, beforehand, I would have poured the saline into the area to make sure that I did have that. So what we are going to do, as I am sterile, we are going to put the irrigation tip together. Make sure the irrigation tool works. We're going to withdraw, and we are going to irrigate left to right. So I'll go down until the area is clean, until the runnage is clear. If it is continuously bleedy, then we do as we would. So keep going back and forth. And let's say this is my final time, and it's running clear. So what I am going to do now is we are going to do measurements. So I do have my tool with me, my measurement tool. So what we are going to do is dip this in saline. And then what we are going to do is measure. So first we'll do our length, which would be about 5 centimeters. Our width, which would be about 4. And finally, the deepest portion, and measure that. We'll say that's about 3 centimeters. What we're going to do is I'm going to drop this. We are going to use this cotton swab, dip that in saline as well, and we are going to check for undermining and tunneling. So then what I'm going to do is push, 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 push. So I am getting about 2 inches of tunneling of the undermining. That is from 12 o'clock to 6 o'clock, and then from 6 to 12. Right. So then I would throw that away. Drop in time. So my wound is now clean. I have now debrided it with the irrigation. So we've done that now. Now it comes for the packing. So what we can do is we're going to put our gauze. We are going to place them into the saline a bit, just so they're wet. We're going to wring them out, and then what we are going to do is we're going to fluff them up. This is going to improve the space that it can do and just make the compaction of it a lot more comfortable for the patient. So just fluff it up. What we are going to do is I'm going to use tweezers. Ideally, if I did have extra cotton swabs, I would actually use those instead, because those are a lot more comfortable in terms of pushing them into the client. Do the same thing with this one. So what we'll do is we'll fluff it up. And then we'll ball it up. So what we're going to do is you're not going to pack tightly, but we're going to pack snugly to make sure that there is space for the wound to breathe, and so that we can, so it's not restricting any airflow to the area, or else that can cause more damage than we are expecting for the wound. Okay, and we'll make sure that any of the tunneled areas are being packed. During this time, I'd also be asking the patient how their pain level is doing. So, Mr. Gale, how's the pain level doing? Are you having any severe pain from this? Not really? Just twinges? Okay. If they were having a lot of pain, we'd be possibly increasing their pain medication. We'd be asking for another nurse to maybe give maybe IV medication, such as IV morphine or IV hydromorphone, to be able to reduce the pain level. I'm going to say I need one more packing, because you don't want it below the edges, but you don't want it above the edges. Perfect. So I would say that covers our area. What we shall do now is we are going to get our padding. So we'll put maybe one here and another one here to cover the wound. And now that I've touched this, my hands are no longer sterile, but clean, but I no longer need them to be sterile, as the procedure is already completed, and all I need to do is place the dressing onto the wound. So one there, and the last piece of tape goes onto the bottom. And that is my sterile dressing for a complex wound.